Exotropic, exotropic. Okay, I'll show you his 9 position of gaze. And what do you, very nice, on the right side. In addition to the upshoot, you see what? Narrowing and limitation of adduction. You know, the eye does not really adduct, as you said earlier. You know, and at the same time, you see here, yeah, exactly right. So, you know, the hallmark for any Duane retraction syndrome, you know, is that they have to have all of them. Limitation of abduction. Limitation of abduction. Okay, so that speaks for Duane type what? Type 2. Type 2. In type 3, it's really like more complex, we think, you know, the wiring is really like, you know, from both the 6th and 3rd nerve to both the medial and lateral thigh muscles. And you know that is reflected clinically in limitation of abduction and adduction. Okay. Very often, and is very often also overlooked, is that the presence of other, you know, anomalies in association with Duane retraction syndrome. And you will find ocular and non-ocular findings. The best I have ever seen and read about this is in the Scandinavian literature. And there is somebody really who reported this very well, actually. I think she got some prize from the Academy. You know, in Scandinavia, at least in the past, they will have a medical record for each Scandinavian citizen from birth to death. They will have the same medical records. So this lady, a doctor, she looked back into all the medical records of patients with Duane retraction syndrome, and she witnessed, you know, she like specifically thought what happened during pregnancy. She thought that there is really like something that should have taken place during pregnancy that has resulted into this. And to our surprise, actually, she gets something very interesting. I think, if I am not mistaken, at the 6 weeks of the gestations, the mother either had a medicine or exposed to radiation, and that, you know, she thinks is really related to this. And consequently, not only the Duane retraction syndrome, the other associated anomalies, she really followed back, and she found that the development of these anomalies takes place at the same time. Do you recall in medical school something, you know, that you know, brings memories, something like this, when you had pharmacology? Have you heard of thalidomide? Very ممتاز يا دكتور. Oh, ممتاز. Yeah. So, you know, it's great to know what's going on, but it's also really good to read about the history of these things and try to understand. Many syndromes. Yeah, so you can see that a lot of things does take place around, you know, around the 6 weeks of gestation, as I said earlier. And I think if you look up the literature, you will find, you know, the paper where she did describe this. Okay. What do we say? What are the other features of the Duane retraction syndrome? What is really like, you know, we talked mostly about the motor part of the Duane retraction. I said limitation of abduction, adduction, ESO, exo, upshoot, downshoot. What are the other, you know, like the sensory findings associated with Duane retraction syndrome? And when we say sensory, what do we mean sensory? It's very often in amblyopia. Sure. Okay. It's very often overlooked, especially in the North America, you know, training, which is mostly our way of training. The sensory findings are very important. We tend to be much more, you know, concentrated or focused on the alignment and the motor alignment of the, and we tend to forget a lot about the sensory findings. The sensory finding is really like what? Suppression, diplopia, confusion, these things. Do you recall what's the difference between diplopia and confusion? Diplopia is what? MashaAllah عليك يا دكتور. Perfect. Perfect. Okay. Perfect. So, you know, in Duane retraction syndrome, they have normal sensory findings. In fact, if you ask somebody with a Duane retraction syndrome and you ask him to the field where their deviation is manifest, what does he or she complain? They usually complain of diplopia, and this is why they avoid. And exactly right, صحيح, mashallah. They adopt head position. What kind of head position? We overlooked this point. In which type? Type 1. And in type 2. MashaAllah. Okay, so we said they usually have a normal sensory findings. And how about amblyopia? You think, how prevalent is amblyopia and Duane retraction syndrome? Anisometric. ممتاز يا دكتور. صحيح. In the old literature you will find really contradicting notes about amblyopia. You will find some books they say Duane patients, they usually do not have amblyopia, and the reason for that is that they adopt head position and they have binocular vision, like normal sensory findings. But in many times, which is true, in most of the patients, but still you do see patients with amblyopia, and if it does occur, it's usually, as the doctor said, it's anisometric amblyopia. Usually, what kind of anisometric amblyopia here? High myopia, high hyperopia, astigmatism. ممتاز. صحيح, astigmatism, mostly astigmatism. So, this really makes us, our work, we have to be thorough. We don't really take them lightly. They said to the parents that they have Duane retraction syndrome, you don't need to worry about anything. It's really important that we refract this patient and give them the proper correction. As we said, we don't like, type 1 and type 2. It's much better if we see a patient with Duane retraction syndrome, we describe the clinical features. It's really very useful, for us, rather than say type 1 or type 2, to describe the clinical features present, like primary position, ESO or EXO deviation, upshoot and downshoots, A and B pattern, eyelid changes and globe retraction, torticollis, which is, what's torticollis? Head position, another word for the head position, and whether it's unilateral or bilateral. You will find these features, clinical features. These are the features that the patient come and complain to you about. Some patients, they have Duane syndrome, and their main feature is that their primary position, they're really concerned. They don't mind, like an upshoot or downshoot in right or left gaze, but their primary position is really most important to them. So, if you describe them well, it will give you a very good, impression whether I should do surgery or I should not do surgery. And when you talk to the patient and to the parents, you will really tell them, I'm going to do the surgery specifically for this thing, because you cannot really make them 100% or as good as the other normal guy. Okay. There are therapeutic modalities, and as we said, we have to really set up the goals of our treatment. The surgical procedure, either horizontal muscle surgery or transposition procedure. What are the transposition procedure that you know of in strabismus? NAB procedure. بس حسألك عن كل واحدة ترى. Can you please tell me what is NAB? هيك كانت دكتورة. ما شاء الله. طيب وهمل شاين؟ قالت واحدة ثانية همل شاين. You don't know. ممتاز ممتاز جميل صحيح جدا. تندن جميل دكتور عبد الله. تندن ممتاز. أي. Together with what? Together with the last. الله يعطيك العافية دكتور عبد الله. ممتاز ممتاز. Mumtaz. You know, these are really various types of, you know, transposition procedure. Usually when we talk about Duane, which one we would really consider? Duane retraction syndrome. Would we transpose the lateral and medial upwards? Very unlikely. We usually transpose to the lateral in order to correct a large angle primary position esotropia. Maybe we can use that. Okay. Other modalities, the posterior fixation suture. What's the name of the other name of posterior fixation suture? Procedure. Very good. Okay. And you know the approach to the upshoot and downshoot. What kind of procedure we usually do if we want to do for the upshoot and downshoot? نعم. ممتاز يا دكتور. صحيح. Yeah, sure. Then we can talk about, you know, consider adjustable sutures. What do we mean by adjustable sutures? Adjustable suture. Haven't you not heard of this? In adjustable sutures, we, you know, we can readjust the position of the muscle after a patient is awake. Usually we do this surgery under GAs. Adjustable suture, yes, we do and prepare everything as if it is really like closed, but we leave it open for us to really like, you know, enhance our outcome when the patient is awake, and usually done in adult patients. Chemodenervation, what do we mean by chemodenervation? Botox, yeah, Botox is most common. Do you think there is a place for Botox in Duane retraction syndrome? There is? Usually not. Usually not. Yeah, you know, it's a retraction and usually it doesn't work. And, you know, we can talk about complications. Okay, here is some, you know, useful information. However, I don't really expect you to remember this. You will find them different in different textbooks. You know, just as a quick idea, you know, for a small angle primary position esotropia in a Duane type 1, you know, we resist one medial rectus muscle, which is really actually the most common procedure in this case. But, you know, we should really be careful, you know, telling the parents what would be their expectations. You know, they will have an improved in primary position, maybe improve their head position, but it will not go all like 100%. So, you know, you'll find many patients, first visit, they are very happy and excited, but then they come back and they say, look, doctor, it's the same, because they forgot what was their child head position like before the procedure. For a larger angle, we can do a medial rectus research and more than 5 millimeters. Okay. Yeah, for exotropia, also we can really like either do a recess of the lateral rectus and yeah. What would be the disadvantage of recessing the lateral rectus like 8 millimeters and more? Somebody with a Duane type, what type will do lateral rectus recession? Type 2, because they have exotropia. What would be the disadvantage that you should really caution your patient about before that? ET? You think they will develop ET? What? Actually, it will be more limitation of abduction, because by default, we said all Duanes, they have a limitation of abduction. And if you even further recess the lateral, yes, you will correct his primary position, but you should really caution him that there will be further reduction in his abduction. Okay, now here is something interesting. You know, we talked about upshoot and downshoot. There is a differentiation between an abrupt upshoot and a slow upshoot. Yes, Doctor? Mumtaz. Which is which? جدا رائع ما شاء الله. A+ ما شاء الله تبارك. Okay. So what would be the procedure for each one of this? In abrupt, you know, upshoot of the, yeah. You know, that as the doctor said, maybe a Y split of the lateral, because you know it means that both have really contracted at the same time, that the globe did not find anywhere other than going up. While in the slow, as neurological, as the doctor said, will aim to do what? Superior rectus recession, if it is significant. Differential diagnosis, either sixth nerve, Mebius syndrome. Mebius is what? What's Mebius syndrome? Fifth, sixth, خمسة ستة سبعة ولا ستة وسبعة بس؟ ها؟ ستة سبعة. Okay. What do you think? Okay. Okay. Maybe you can look it up. I'm not sure, but I know that 6 and 7 are involved, but I'm not sure about fifth. Or congenital oculomotor apraxia. Have you seen this? Congenital oculomotor apraxia. It's a very interesting phenomenon. If you see it once, you will not forget it. Maybe you can watch it on YouTube. It's really interesting. In this patient, they don't have a pursuit movement. They have a saccades. So what they do in order to see things, they head thrust. جدا رائع صحيح. They trust. Unless you see it, you know, you can remember it and memorize it. But if you see it, it's really interesting. And I'm sure you will find you know, very good videos of this. And infantile esotropia. How do we differentiate infantile esotropia from Duane? صحيح. ممتاز. How do you confirm, how do you display الابيدكشن? Ductions, you know, sometimes babies do not cooperate. Doll's eye, very good. Can you explain to me how do you do doll's eye, man? Have you tried it, doctor? Have you tried it? صحيح. أيوة. How do you do it, doctor? ممتاز صحيح. Or you can rotate the chair. يعني it's not easy, especially in a small baby and the mother is very concerned and so on. So sometimes it's really difficult. But the point you have mentioned earlier is very good. You know, one very important thing doctor has mentioned is that the angle of deviation in infantile esotropia is very large compared to Duane retraction. So it's interesting, you know, despite the limitation of abduction, يعني زي ما تشوفوا abduction is almost zero in the patient I have shown you earlier. I can go back if you want me to show. Yet the esotropia is barely seen, like 20-30 doctors. If you have somebody with a 6-nerve palsy and this much of limitation of abduction, what would be his esotropia in primary position? يعني لو واحد ما يقدر يحرك عينه diabetic, you are in the emergency room and you saw somebody with diabetes and he has a 6-nerve palsy. If they have 6-nerve palsy, they usually أول شيء يجي هو مغمض عينه طبعا and he's complaining of what? Diplopia, and he doesn't like it. And when you try convince him, please open, you will find what kind of angle? Large angle. ليش؟ لأنه it's a paralytic strabismus. يعني ما في antagonist to the medial rectus muscle function. One of the hallmark for Duane, despite يعني في discrepancy between the limitation of abduction and the angle of deviation. تلاقي almost there is no limitation, there is no abduction, يعني zero abduction, and yet at the same time the angle of deviation is very minimal, 20, 30 at max. If you have somebody with a 6-nerve palsy with a limitation, with limited abduction, he will have 60, 50, 40 at least, if not more. So this is one of the things that, and also in infantile esotropia, they usually have large angle, as you said. Okay, I will go quickly to Brown syndrome. I hope the hallmark for Brown syndrome is the defective elevation in adduction, and less defective elevation in midline, and minimal or no limitation of elevation in abduction, which is one also very important finding is that minimal or no supraoblique overaction and divergence in upgaze producing a V pattern. You know, this is important in differentiating Brown between what from another, from what? Inferior oblique pulse. What would we get? You will get a pattern, inshallah. Excellent. And you know, the hallmark for a Brown syndrome is really to have a positive forced duction. You cannot say this is a Brown syndrome unless you do forced duction and you have a limitation of elevation in adduction. We get here, you know, widening of the palpebral fissure, you know, when we saw the first picture, and you know, in relative to that, and anomalous head position. What would be the usual anomalous head position in Brown? Ipsilateral. It's actually, you know, a chin up. It cannot be ipsilateral. Yeah, good. And primary position, hypotropia. Hypotropia may or may not be present in primary position. What do you see here? On the left side, you see the eye is going down, actually, rather than, you know, going up like the other side. Okay. There are different classifications for Brown. Here is some, you know, like a true versus simulated Brown, congenital versus acquired Brown syndrome. As the doctor said, you know, the differentiating points from inferior oblique paresis or palsy. How often is inferior oblique paresis or palsy? Very rare. You're right. You're absolutely right. In fact, many people, they don't think that this entity exists. But, you know, so the hallmark, as the doctor said, is that you don't get a superior oblique overaction, which is the antagonist of the inferior oblique. If you have some muscle palsy, you get the antagonist overaction. In inferior oblique paresis, you get a superior oblique overaction, and consequently, you get what? An A pattern, rather than, you know, a V pattern, which we just mentioned, you know, in Brown syndrome. Okay. One of the classifications for the Browns, mild, moderate, and severe. It's actually useful to remember this. You know, in mild form, you have a restricted elevation in A deduction, however, no hypotropia and no downshoot in A deduction. In the moderate, you have limitation of elevation in A deduction with downshoot in A deduction, however, no hypotropia in primary position. And in severe form, you get both. The limitation and the head position and the downshoot and the hypotropia in the primary position. Remind me later. Okay. And you know, there are several theories about the etiology of the Brown syndrome. One of them is that, you know, you have an abnormal relationship between what? Between the superior oblique tendon and the trochlea. Yes, yes. And you get consequently, you know, kink. Here is a synovial joint. We should really always remember this. So people with rheumatoid arthritis, they might get an acquired Brown. This is a synovial joint. Thank you very much. You have questions? Thank you. If you don't have questions, then yes, you do. When we do the correction, yes. Not really, not really. You know, the aim is really to get the head position rather than in this way, is to get him to be straight and see binocular when he's straight. You're, yes, but binocularity with a head position, you know. He's having the harmonious retinal correspondence with this head position. So you're just trying to move this, position into the primary position, moving the muscles. Not really, not really, not really. No, yeah, unless you do something wrong, unless you do it the wrong way, then yes, you can really give troubles. But in general, no, not really. الله يحييك أهلا وسهلا دكتور. Thank you.
شغلها من هنا.
ممكن تنزل.
شكل حجمه كبير صار.
70 ميجا. بس باقي 10 minutes.
السلام عليكم ورحمة الله. كل عام وانتم بخير وشهركم مبارك. Today our presenter is Dr. Hatem Clinton. Dr. Hatem is well known to everybody. He is the Associate Professor, Consultative Ophthalmology, Department of Ophthalmology at King Saud University. He is the Deputy Chairman of the Saudi Ophthalmology Society. He is Vice Chairman of the Department of Ophthalmology at King Saud and the Chief of the Unit of the Cornea Unit. He will speak about topographic diagnosis of keratoconus. Can we detect it earlier? I hope you will enjoy the lecture. Hatem.
Thank you, Professor Hani. Good afternoon, everybody, and كل عام وانتم بخير. My today's talk is about the diagnosis of keratoconus and whether we can diagnose it earlier than we are doing today. So why would we are interested to diagnose the keratoconus? The ability to detect early keratoconus and subsequently monitor the cornea for the progression of the disease has become an important clinical skills. Why we want to detect it early as possible? Because since the introduction of the cross-linking which halt the progression of keratoconus, the management of keratoconus has significantly changed. So this made the early diagnosis is so important. The earlier the keratoconus can be stopped, the better the vision-related quality of life of these mostly young patients. And conversely, missing a diagnosis of early keratoconus in patients seeking refractive surgery, which is widespread and common nowadays, it can lead to significant consequences if ectasia subsequently develop. So keratoconus, it is a progressive non-inflammatory bilateral but usually asymmetric ectatic corneal disorder. It is characterized by paraxial stromal thinning and weakening that lead to corneal surface distortion. The pathophysiology of keratoconus, all layers of the cornea are believed to be affected by keratoconus, although characteristic structural changes include epithelial basement membrane, fragmentation and scarring, and breaks in the Bowman membrane, which is characteristic of this, with axial stromal thinning and scarring. The stromal thinning of keratoconus, it is thought to be related to a combination of increased activity of proteinase enzymes and decreased proteinase inhibitors, with subsequent reduction in the biomechanical stability of the cornea. So how would we diagnose keratoconus? As usual, we start with the history, and keratoconus should be suspected in any patient with significant irregular astigmatism, especially if unstable and increasing or deteriorating over time. And the examination, which with the unique finding of keratoconus that I will come to mention to you, and then the imaging, which is nowadays the gold standard for the diagnosis of keratoconus. So in the history, few points has to be considered. The frequent changes of eyeglasses, which doesn't or don't adequately correct the vision in the way the patient is satisfied with, and also history of eye rubbing, which is known to be a correlation with the keratoconus, and also to have a systemic history to rule out other association with keratoconus like Down syndrome, atopy, Leber conjunctival amaurosis, connective tissue diseases like Ehlers-Danlos or Marfan syndrome, and many others. Also the family history of keratoconus due to the genetic correlation with keratoconus in the families. And the physical exam, they can have early sign or late sign of keratoconus. The early sign consists of asymmetric refractive error with high or progressive astigmatism, and the keratometry showing high astigmatism and irregularity, the scissoring reflex by the retinoscope, and the inferior steepening skewed axis or elevated keratometry value on key reading, and topographers, the corneal thinning, especially inferior cornea with a maximum thinning, correspond to the site of maximum steepening or elevation, and also the Risotti sign. When shining the light from the temporal side, you will see a conical reflection on the nasal cornea. Fleischer ring, which is the deposition of iron on the base of the cone and the Vogt-Stray signs of keratoconus. Later on, we can see Monson sign, which is the protrusion of the lower lid in that case, superficial scarring, breaks in Bowman's membrane, and sometimes acute hydrops can happen, which result in sudden decrease in vision due to a break in the cement membrane, which allow aqueous to the stroma, causing corneal edema and decrease in vision. And when this acute hydrops resolves, usually it ends up with a stromal scarring and flattening of the cornea, which paradoxically may improve the vision in some cases by changing the curvature. So now to the imaging, which is now the gold standard for the diagnosis of keratoconus. We started by the corneal topography, which in the 1980, applied pseudodisc-based instruments such as the topographer. They provided good qualitative and some quantitative data on the anterior corneal shape, not the posterior, not the corneal thickness. It utilizes concentric rings of light, which the placido disc in combination with digital camera to capture the image of the reflection of the said rings by the anterior surface of the cornea, which are processed in algorithm and gives us these images, which we all know for the corneal topography. What are the patterns that makes a suspicion in the anterior topography? Asymmetrical bow tie. So usually with regular astigmatism, we have a symmetrical bow tie, but when this bow tie becomes asymmetrical, we have to raise our suspicion. A symmetrical bow tie with skewed radial axis like this also should raise suspicion to the diagnosis of keratoconus. Inferior steep asymmetrical bow tie or superior steep asymmetrical bow tie, or asymmetrical with skewing like mostly we see in the keratoconic patients. What are the indices that should make us suspicion of the diagnosis of keratoconus? Astigmatism more than 5 diopters, or keratometry value K1, K2 more than 48, or the maximum keratometry, or what we call Kmax reading of more than 49. The central corneal thickness of less than 470, or corneal asphericity of more than 0.5, which is normally from 0.2 to 0.8. Superior value when it is more than the inferior value in the corresponding area of the cornea of more than 2.5 diopter greater than the lower value of the inferior value. This should raise a suspicion, but if it is inferior, it has lower threshold of only 1.5. So if the lower is more curved than the upper, this has to be only 1.5 difference. But if the upper is steeper, it has to have 2.5 difference to achieve significance. This is one of the indices that were derived from the anterior corneal curvature, which is the keratoconus prediction index. And objective is to detect keratoconus and then to just grade it and monitor the progression. This keratoconus prediction index combination of 8 topographic parameter, which is a flat K, steep K, and some index called surface asymmetry index, and the differential sector index. Differential sector index is the difference between the steepest and the flattest area of the cornea. The opposite sector, it has to be corresponding area, inferior and superior, and the center surround index and irregular astigmatism index and the analyzed area. So these are 8 indices that come together to form the keratoconus prediction index. They found that the cutoff value of 0.23 was determined to have the best sensitivity, specificity, and accuracy. So if this keratoconus prediction index is greater than 0.23 for this anterior topography, this suggests that the eye has keratoconus. Another index, which is called the keratoconus severity index. The keratoconus severity index utilized total of 10, not 8 indices, including all the ones that are calculated in the prediction index, except for the K1. But additionally, it utilizes the cylinder, the corneal cylinder, surface regularity index, and standard deviation of the corneal power. The keratoconus suspect produced values of 0.15 to 0.29, while clinical keratoconus produce more than this value in the range of 0.31 to 1.0. There were some diagnostic criteria made by Rabinovich, and these criteria include the following three indices: and OCT pachymetry measurement inferior superior value and minimum pachymetry, which when abnormal suggests the diagnosis. Here are the K values, which measure the central steepening of the cornea. A value of 47.2 or greater suggests suspicion of keratoconus. The inferior superior value, which measures the inferior versus superior, mentioning it again, so the inferior is more steep than the superior with a difference of 1.4 diopter. It also suggests keratoconus. The KSA index, which is a percentage incorporating K reading and IS values with a measure of quantifying the regular and irregular astigmatism into a single index. A value range 60 to 100 suggests keratoconus, and more than 100 it is a frank keratoconus. The pachymetry asymmetry index, the minimum pachymetry value divided by the inferior superior value. Identify keratoconus suspects and form frost when this value, which is the pachymetry asymmetry, is less than 105. It is suspicious diagnostic of keratoconus. Also, with this topographer, it came out to have some classification to grading. The first classification, or the old one, is Amsler-Krumich classification for keratoconus. The stage 1 is concerned with eccentric steepening, myopia, astigmatism, or both. The astigmatism is less than 5 diopter. So if the astigmatism is less than 5 diopter, it is a stage 1, and the mean K reading is less than 48. So if it is progressing to stage 2, the astigmatism will range from 5 to 8 diopter. The mean central K, instead of 48, it will be up to 53, and there will be no scarring. The corneal thickness is still more than 400. In stage 3, the corneal thickness is less than 400, in the range of 300 to 400, with the astigmatism ranging from 8 to 10 diopter. The mean central K will be more than 53, with the absence of scarring. The stage 4 is when the scarring happens, and the refraction is not measurable, with the mean K reading is more than 55 and a very thin cornea of less than 200 micron. This classification didn't take into account the posterior corneal curvature or the corneal or the thinness pachymetry or the visual acuity. Another more recent ABCD classification emerged, and ranging from stage 0 to stage 4, and A having certain diopteric power for the anterior corneal curvature, and going from very mild to very severe, and B is the back corneal curvature. Either it is interpreted in millimeter or radius or curvature, or in the diopteric power. Also, it is ranging from low to high, and this take into consideration as well the pachymetry of the cornea, which is also ranging from high to low, and the best corrected visual acuity. So these classification are derived from the topographer and helps us to stage the disease and to monitor the progression and to offer the treatment required for each stage. So how we diagnose by the topography? These are the limited assessment because of anterior, only measuring the anterior corneal surface. It doesn't take into account the pachymetry or the posterior surface, and we know now that keratoconus start earlier on the posterior corneal surface, and then it will be manifested to the anterior corneal surface. Therefore, changes in corneal thickness and posterior corneal surface elevation, which are known to be detectable in early keratoconus, placido disc or anterior surface topography. Then came the tomographers. The tomographers, they provide us with a detailed analysis of the shape of the anterior and posterior corneal surfaces, as well as thickness, tissue distribution of the cornea. The two most famous tomographers nowadays are the Orbscan 2 and the Pentacam, in addition to Galili, and they provide us with elevation map rather than a reflection map. So this is the Orbscan 2, which utilizes a combination of placido rings and scanning slit to assess the shape power of the anterior and posterior corneal surface, as well as corneal thickness. So the patient shall sit like the slit lamp, and the machine takes a picture of the cornea, providing us with these 4 color-coded maps, which are the anterior corneal curvature, anterior corneal float, and posterior corneal float, and the pachymetry map, and the curvature map. In the posterior float, we are seeing the posterior elevation as it manifested early on in the disease, and then it becomes manifested on the anterior corneal float, and the corneal pachymetry becomes thinner and thinner as the disease progresses. And here in the curvature map, we can observe the pattern of the keratoconus in the form of inferior steepness or skewed axis. There are some score that was derived from the Orbscan, which is the screening corneal objective risk of ectasia artificial intelligence system using a linear combination of 12 tomographic indices obtained with the Orbscan, including the maximum posterior elevation and the thinnest corneal thickness, and vertical decentration of the thinnest point, and the difference between mean central corneal thickness and the thinnest pachymetry. It derives a compound score where a positive score more than 0 is indicative of a suspect of keratoconic cornea, and a negative of less than 0, it is normal cornea. Then a few words about the Pentacam, which is also an elevation map tomographer and can perform other functions, viewing and imaging of the anterior segment. The Pentacam utilizes a single rotating shine flow camera along with a 14 mm monochromatic slit illumination composite blue light emitting diode for 75 nanometer. And the slit beam produces an illuminated section which is imaged 12 to 50 times by rotating the shine flow camera corresponding to specific angles along the optical axis. This is the Pentacam picture as it's showing also the 4 maps of the posterior elevation and anterior elevation and the pachymetry and the curvature map. We can see here some posterior elevation as it indicates the early keratoconus. This is another picture of Pentacam showing advanced keratoconus, in which the posterior elevation is so progressed to be manifested also on the anterior elevation, with a thin cornea and inferior steepening on the curvature map. You can diagnose easily the keratoconus. There was also another data or display that is derived from the Pentacam, which is the Bellin-Ambrosio enhanced ectasia display or BAT display. The posterior and anterior elevation data is calculated in this display using enhanced best fit sphere, which exclude the 3.5 millimeter cone and making the best fit sphere starting from this area. So if we didn't use the Bellin-Ambrosio display, the machine shall average the elevation and depression on the cornea and make the best fit sphere in this area. And this specific sphere is the reference point below or above which the device is measuring. If the point of the cornea is in front, it gives plus numbers. If the point of the cornea is behind this specific sphere, it gives negative number. So if the machine would draw the specific sphere here, the elevation here will not be too much. So we can miss a diagnosis of early keratoconus, for example. But this display, it identified the 3.5 millimeter or 4 millimeter area of the cone and draw the specific sphere or the reference point on the base of that. So if any elevation above that will be much, much more enhanced. So any area that is suspicious here in the usual display will become more enhanced in the Bellin-Ambrosio display. It has certain indices in this display, which is the DF, which is the deviation from normality of the anterior elevation, DB, deviation from normality of posterior elevation, and DP, which is deviation from normality of pachymetry progression, and DT, corneal thickness deviation, and the A is the deviation of normality of relation thickness. All of this will have an average, and this average, which is the mean of the normal population, the zero value, and positive value represent standard deviation toward the disease, and software highlighted values between 1.6 to 2.6. So if it is more than 2.6 of the D, it is indicating that there is a clinical keratoconus. If between 1.6 and 2.6, it is a suspect keratoconus. Where can we find this D? It is here. These are the 5 and the average, and it tells us information and an index to facilitate the diagnosis of keratoconus. The difference map depicts changes in elevation as a series of concentric green, yellow, and red circles. The green represents change of less than 5 millimeter on the anterior surface, 12 on the posterior surface of the cornea. Yellow changes, yellow means borderline of 5 to 7 millimeter for the anterior surface, 12 to 16 for the posterior surface, and red, which is the diagnosis of keratoconus, it is greater than 7 anteriorly and greater than 16 posteriorly. So if we saw, this is the usual posterior elevation. This is the posterior elevation with enhanced specific sphere, and you can see the numbers here getting much more prominent. Here is the difference between the two, and usually if you saw this yellow or red numbers, it is significant. And same applies for the anterior elevation. There is also a holiday 6 map display. The holiday 6 map display, it is the usual 4 maps plus the front surface tangential curvature. Tangential curvature, which is enhancing also the curvature of the cornea, which is called instantaneous curvature, and also the relative pachymetry. This is the instantaneous or tangential curvature, and this is the relative pachymetry. The values represent the percentage above or below the predicted thickness map. So if there is a steepening on the tangential map, as we can see here, along with thinning on the relative pachymetry map and elevation on the posterior float more than 10 millimeter, then diagnosis of keratoconus is evident. So what about the corneal pachymetry? How can we use it to diagnose the keratoconus? The important consideration is the displacement of the thinnest point of the cornea. The thinnest point, usually it's not far away from the center of the cornea, but in keratoconus it becomes more displaced from the center of the cornea. Abnormal cornea, the thinnest point is displaced inferior or inferior temporally of more than 30 micron. Another consideration is the pachymetry progression, which is in keratoconus. Usually there is thin in the center and getting steeply or progressively thicker to be very thick in the periphery. While if it is only normal thin cornea, it will be thin all the way to the periphery. So keratoconus thin in the center, and as it goes to the periphery, it becomes very thick in disproportional way. Normally thin cornea, it is all thin. It becomes thicker, but not in a very significant way. The main limitation of the current corneal tomography technology include difficulty in distinguish pseudoectasia, for example, following hyperopic excimer laser refractive surgery, and the poor accuracy of these devices if there is any scarring or haze in the cornea, because these devices utilize the light to have the image, so whenever there is a scarring, it will be having limited or unreliable data, which is not infrequent in keratoconus. And also the clinicians report eyes with normal topography and no other known risk factor that still develop post-LASIK keratectasia. It's likely that the corneal tomography doesn't capture all the cases at risk. So let's go back to what happens in keratoconus. Keratoconus or keratoconic corneas, they have abnormal or defective enzymes in the lipid peroxidation and or nitric oxide pathways, leading to oxidative changes and damage. The accumulation of oxidative cytotoxic byproducts cause alteration of various corneal proteins, triggering cascade of events which cause apoptosis, alter signaling pathway, increase enzyme activity, and fibrosis. All of these mechanisms, it will produce at the end a cornea that is not as rigid as it should be, and the corneal rigidity will be decreased as because of this. So to start with, for any patient having keratoconus, he has to have the genetic predisposition for that, and then this genetic predisposition will be translated to alter metabolic activity in the tissue of the cornea, which lead to biomechanical abnormality. The cornea is not rigid as the normal cornea, and when this progresses and the cornea protrudes, we will see that in tomographic changes like the pentacam or the orb scan. And if it starts in the posterior surface and then it's just beginning into the anterior surface, there will be some compensation from the epithelium trying to mask out that anterior protrusion, becoming thin over the cone and thicker in the nearby area to mask it. So these epithelial changes happening after the tomography, and by the time the epithelium can no longer mask these curvature changes and the protrusion becomes evident onto the anterior surface, there will be some topographic changes, and then at the end the refractive surgery. So now we are detecting or diagnosis keratoconus in this area, which is pretty early area, but can we detect it earlier? For the genetic testing, a lot of research has been done to identify what are the genes that are associated with keratoconus, but it turned out that keratoconus is a complex disorder, and it involves multiple genes and various mechanisms that contribute to the clinical disease etiology. Certain genes such as VISX1, DOC9 and TGFB1 may have an essential albeit sufficient role in the disease, but due to, as I told you, the heterogeneity of the disease, the role of genetic testing in screening of keratoconus is still limited. What are the biomechanical changes? The impression cytology, which we use for other disease entity, is a technique which permits the retrieval of the outermost layer of the ocular surface cells via the use of various type of filters, either sticky tape and take the cells that comes with the conjunctiva, or due to with the use of certain devices. They are commonly described, the keratoconus commonly described as non-inflammatory, but some studies have reported impaired tear secretion and dry eye disease in keratoconus patients, so it might not be a non-inflammatory as we used to describe the keratoconus. It has some inflammatory component. A pilot study by Carasido et al. They investigated keratoconus patient, 15 patients, for the presence of the dry eye using morphological assessment, goblet cells by the impression cytology. They found out that compared with healthy controls, 16 patients, the keratoconus patient demonstrated significant lower density of goblet cells with a significant p-value, once more showing how impression cytology may be reliably used to assist in confirming dry eye disease diagnosis. More recently, keratoconus research has employed conjunctival impression cytology alongside the tear osmolarity or tear breakup time, the Shermer, and ocular staining to monitor the ocular surface and tear changes pre and post corneal collagen cross-linking. This study of 26 patients with progressive keratoconus showed a statistically significant increase in the impression cytology grading superior and temporal, and respectively at 3 months post-treatment. What about the corneal biomechanics? So the structural changes and biomechanical changes by the use of impression cytology is not that advanced to screen for early keratoconus. The corneal biomechanics, which is the measuring the elasticity or the dampening effect of the cornea, is an important factor to detect early keratoconus. It was shown that underlying reduction in the corneal biomechanical strength has been postulated to precede the corneal tomographic changes in keratoconus. So what happens usually is the cornea becomes weak, then with its weakness it protrudes forward and show us the changes in the tomography. So can we detect the weakness of the cornea in this stage before it evolves into tomographic changes? The reduction in biomechanics is due to the several factors, such as loss of stromal fibrils, altered orientation of individual collagen fiber, reduced number of crosslinks, and keratocyte dysfunction. Currently, there are 2 machines that we use to measure the corneal biomechanics. They are the ocular response analyzer, which is the Aura, and the Corvus. The ocular response analyzer, it is the first commercially available device claimed to measure the corneal biomechanics in vivo. Use a meter air pulse, so it puff an air into the patient cornea, it indents the cornea temporally, and measure the infrared reflectance profile over the ocular response. This produces 2 distinct infrared reflections, peak once while the cornea is moving inward, and then the cornea moves outward to assume its original shape, and during this applanation stage it has another peak. So how does it work? Precisely metered collimated air puff is directed to the cornea. It moves the cornea inward to flatten it post-applanation into a slight concavity. The infrared applanation detect system monitors the cornea throughout the entire process. It draws a peak with applanation. When it is totally flat, it draws a peak, and then the cornea goes in. And millisecond after applanation, the air pump shuts, and the pressure declines in a smooth fashion. As the pressure decreases, the cornea goes back to return to its normal configuration. Flat, then concave, then flat again, and another peak will be drawn by the device. You would expect that the pressure during in and out in the flat stage to be the same, but the cornea has some dampening effect. So when it goes in, it is delayed a little bit so that the pressure on the outward applanation will be less. So there will be a difference between the 2 pressures. The difference between the 2 pressures, it is called corneal hysteresis, and it is a measure of the corneal dampening effect. Whenever the corneal hysteresis decreases, it means that this cornea doesn't have a dampening effect, and this applies to keratoconic corneas. The 2 primary biomechanical output from the ocular response analyzer are the corneal hysteresis and the corneal resistance factor. Both parameters have been reported to be significantly lower in keratoconic cornea. So it is 8 point something to 9 and 7 to 8 in keratoconic cornea. The corneal hysteresis and corneal resistance factor respectively, compared to healthy corneas. So this corneal hysteresis, which is the difference between the applanation pressure inward and the applanation pressure outward, is the hysteresis. Whenever it is high, it is good. Whenever it is lower, this means that this cornea is flaccid, or it doesn't have the enough rigidity of normal cornea. The limitation of this, there is considerable overlap between population for both parameters, the hysteresis and the resistance factor. This presents as a major challenge when using aura as a diagnostic aid. So there is overlap. You can use this as a supplement tool to diagnose keratoconus, but not a sole tool to diagnose the keratoconus. No significant difference between mild and normal eyes in terms of hysteresis. It has some 91% sensitivity. CRF, which is the corneal resistance factor, is only 81 sensitivity, which is considered to be low to detect keratoconus. The other machine is called the Corvus. Corvus is a machine that is produced by the Oculus company, which is the same as the Pentacam. It is the second commercially available device that measures the corneal biomechanical property in vivo. It utilizes an ultra high-speed shine flow camera. It measures a lot of frames, 4,000 frames per second, to record the ocular response to the air pulse. The device records an 8 mm wide horizontal section of the cornea, and individual frames from the video are analyzed to provide an array of physical parameters that enable the interference of the underlying corneal biomechanical properties. So during the measurement, an air puff deforms the cornea inward to the first applanation and then into a concave shape. So the air puff is coming, applanate the cornea, and getting to the concave shape to the point that the highest concavity is achieved. Afterward, the cornea recovers in the outward direction and undergoes a second applanation before returning to its natural position. So here, if you saw in the left, this is a normal cornea, and with the air pressure, it applanates, and then it goes into a concave stage. If you compare this with a keratoconus cornea, there will be more applanation and more going to the concave stage rather than the normal cornea. Then this implies that there is less rigidity in the keratoconic cornea. Once the measurement is performed, the device provides set of corneal deformation parameter based on the dynamic inspection of the corneal response, including analysis of these parameters that are extracted at the highest concavity. These are some of the stages of the Corvus. The first applanation is when it becomes flat going in, and the highest concavity it is when the cornea becomes concave. The second applanation is when the cornea returns to its original stage, and a lot of variables that can be extracted, including the IOP, which can be corrected to the biomechanical status of the cornea. Also here, it is the corneal or Corvus biomechanical index and the tomographic biomechanical index, which became the index that we can detect early keratoconic changes. The keratoconic eye demonstrated less resistance to deformation because they are flaccid compared to normal eye with similar intraocular pressure. Vinciquerra and co-worker, they combined the dynamic corneal deformation response data and the horizontal thickness profile for introducing the Corvus or corneal biomechanical index, a parameter developed based on the logistic regression analysis, which combined deformation response parameter with corneal thickness. So they developed this parameter, and they tested normal cornea versus clinically diagnosed tomographically keratoconic, and reaching a number that have a cutoff to diagnose all cases of keratoconus. This international collaborative study involved one eye randomly selected from 180 keratoconic patient and from a set of normal patient, 478. The results showed that Corvus biomechanical index has 100% specificity and 94.1 sensitivity to diagnose keratoconus. And then they did the validation test for this, the same cutoff point of 0.5. It's classified 98.8% of the cases, so the sensitivity 100% and specificity is 98.4%. The deformation amplitude is the movement of the corneal apex in the anterior-posterior direction and is determined as the highest displacement of the apex at the highest concavity. Ali and collaborators, they compared the dynamic shine flow measurements between normal and keratoconic eyes and found that despite not having a good discriminative ability alone, the deformation amplitude was useful in diagnosis and monitoring the disease. Another study, they compared normal and keratoconic eyes. They found the majority of the biomechanical variables derived from the corvus, which are the deformation amplitude, maximum corneal inward velocity, maximum corneal outward velocity, and maximum deformation area. It was significant between the two groups, which are the normals and the keratoconic eyes. Another index was emerged, which is the tomographic biomechanical index by Ambrosio and his associate. They developed a combined parameter based on the tomographic data from the pentacam and biomechanical assessment from the corpus. This multi-center study introduced a novel index, which is the TBI, tomographic biomechanical index. The studies informed one eye randomly selected from 480 patients with normal corneas and from 204 keratoconic patients, group 1 and 2, along with 72 non-operated ectatic eyes, group 3, and very asymmetric ectasia, whose follow eye, group 4, presented with normal topography. The results, they showed that using a cutoff of 0.79 for the TBI, they provide 100% sensitivity for detecting clinical ectasia, group 2 with 100% specificity. Also, this corpus, it can measure the IOP, and this IOP can be corrected to the biomechanical properties. If you measuring rigid cornea, it will not be as accurate as if you are measuring flaccid cornea. So this device gives you the IOP, which is free of this factor. Study using the corpus, it has demonstrated several parameters which are significantly different keratoconic cornea compared to healthy cornea. Deformation amplitude, which is among them, the resultant maximum inward movement of the corneal apex with the air puff, it is significantly greater in keratoconic cornea. So the keratoconic cornea displays more with this metered pulse of air. If this metered pulse of air in normal cornea, it will displace less. In the keratoconic cornea, it will displace more due to decrease in the rigidity of this cornea. In the keratoconic cornea, it was 1.2531, and compared to healthy cornea, which is 1.08, even after controlling intraocular pressure and corneal thickness. So what about the corneal epithelium? What are the changes? Can we measure these changes in the thickness of the corneal epithelium to detect early keratoconus? As you know, the corneal epithelium is known to mask localized area of elevation and depression in attempt to restore homogeneous optical interfluid. So if the cornea is becoming protruding, the epithelium over that protruding area becomes thinner and the area around it becomes thicker. This action of the epithelium of the cornea, this is to just make the optical surface homogeneous. This is in contrast if you did myopic LASIK, for example, ablating the center of the cornea, you would expect the epithelium in the center of the cornea to be thicker, not thinner. Keratoconic corneas to have a donut epithelial pattern. Donut epithelial, it is thicker around the cone and thinner over the top of the cone, characterized by compensatory thinning over the localized stromal surface cone with a surrounding annulus of thicker epithelium. The epithelial mapping can be outlined using either ultrasound or OCT machine. The OCT machine, which is used for posterior segment as well, this method produces high-resolution cross-sectional image of the cornea using optical light scatter due to broad bandwidth light source in combination with low coherence interferometry. So it gives you a cross-section of the cornea delineating the corneal epithelium with exact thickness, and then the stroma, and then the endothelium. Keratoconus, this translates significant epithelial thinning over the cone with epithelial thickening around the cone, demonstrated histopathologically very high frequency ultrasound and anterior segment OCT study. The OptoView OCT machine, also the ZEOS and the corneal module for the serous Carl allow mapping of the corneal epithelium, so it's not only one machine, more than one machine can give you the corneal epithelial thickness distribution. And this is normal in contrast to subclinical keratoconus. So this area of the cone has the thinnest epithelium over it, and it becomes thicker around it. This is the pachymetry map, and this is the epithelial map. Here is the epithelium, not here. The epithelium here is becoming thinner over the apex of the cone, and around it, the epithelium become thicker. Lai et al., they demonstrated they wanted to reach an index derived from this epithelial mapping, standard deviation maps of corneal epithelial tomography using the OptoView provided the best diagnostic power. Area under the curve was 1 out of 1. However, when considering corneal epithelial tomography differences between form frost and healthy cornea, none of the parameters investigated demonstrated a high area under the curve. Thus, efficacy of using corneal epithelial tomography maps as a standalone for diagnosis of keratoconus is still weak at this point. And this is as the disease progresses from normal to grade 1, the epithelium becomes thinner, grade 2, more thinner, and thinner in grade 4. So this can be also a tool in determining the progression of keratoconus. Other application of keratoconus include detection of risk factor for developing acute corneal hydrops, describe several features associated with increased risk of hydrops like increased epithelial thickness and stromal thinning at the corneal apex, causing higher epithelial to stromal thickness ratio, hyperreflective region at Bowman's. And it is useful also for the follow-up of the hydrops and to expect the recovery period to counsel the patient. Confocal microscopy, it is providing a non-invasive method of imaging the living human cornea at the cellular level, and using the confocal microscopy demonstrated that there is lower basal epithelial density in keratoconus compared with healthy control cells. In the basal epithelial layer, it is less dense in keratoconus, and the difference more pronounced in contact lens wearer, independent of the severity of keratoconus. The breaks in in Bowman's membrane, which allow direct interaction between the epithelium and the keratocyte, have been observed by the in vivo confocal microscopy. The subbasal layer significantly lower density in the keratoconus compared to healthy individual. The use of confocal microscopy technique to produce confluent maps of the subbasal layer of the architecture in normal cornea, the subbasal layer form radiating pattern, which covers the region 1 to 2 millimeter below the central cornea, and closer look in this area reveal clockwise horn-like pattern. In eyes with keratoconus without contact lens wear, there is loss of the normal radiating pattern. Instead, at the apex of the cone, the subbasal nerve from a tortuous network with many bundles forming closed loop, while at the topographic base of the cone, the nerve appeared to run concentrically around the base of the cone. So it showed the studies of confocal microscopy consistent demonstration of lower keratocyte density in the keratoconus compared to healthy cornea. This observation might be associated with the proposed contribution of keratocyte apoptosis, the pathogenesis of keratoconus. And the confocal microscopy also revealed that both anterior and posterior keratocyte density is reduced in keratoconus comparing to controls. The contact lens wearing keratoconic have demonstrated to have lower anterior keratocyte density. So whenever they wear more contact lens, they have less and less cells in the anterior stroma. This is more than keratoconics who didn't wear the contact lens. The posterior keratocyte density doesn't appear to be affected by the wear of contact lens in keratoconic patients. So in conclusion, there are multiple anterior segment imaging modalities that have immensely furthered our understanding of the underlying pathophysiology of keratoconic disease, process, and clinical characteristics. The corneal tomography remains the current gold standard of diagnosis of keratoconic, making it the most widely used clinical tool for keratoconus. However, continued development of the OCT, confocal microscopy, devices measure corneal biomechanic in vivo suggests that it might be benefit of utilizing a combination of these devices of several anterior segment imaging modality in the diagnosis of clinical assessment of keratoconus. This is particularly pertinent to the diagnosis of sub or pre-clinical keratoconus, which remains a challenge. Thank you. Any question or comment or concern? Dr. Saad. After that. Go ahead.
Okay. يعطيك العافية. Thank you, Dr. Karantan. That was very comprehensive review of all the devices to diagnose and check the progression of keratoconus. I think we have a problem nowadays in defining keratoconus. We know how to classify it, but we don't know how to define it completely. We're still having the gray zone. Do you agree with me about the form-fras keratoconus? All of us are still, just putting two terminology, form-fras keratoconus or highly suspicious. And all these devices are not helping us. I noticed that we are over-diagnosing keratoconus by adding these two categories to the keratoconus, to the four, whatever classification you mentioned. But these devices are not helping us. Is there anything other than what you have mentioned, epithelial mapping, anything that give us a clue? The reason behind I'm saying our cornea is much thinner than the Western, and all their data is based on a thicker cornea in comparison to ours. So we end up over-diagnosing it and putting a group of patients, which I don't see it even in the keratoconus consensus group, the consensus group by the Pan-American Association. You heard about that one. That was published a few years ago. So they did all the classification and they ignored that one because they could not reach a consensus. And we are in a place where we can add these two definitions to them. That's number one. Number two, do you find the Belen and Bresso really helping you in doing refractive procedures? And the other thing, I noticed that it's still important to have topography and tomography at the same time, especially for these two patients. So I need to hear from your opinion. In the term of biomechanics, the biomechanics, I don't see anything coming in horizon in our region, because I think aura now, even in the States and in Europe, is not applicable anymore, because as you mentioned, it's going toward a well-defined keratoconus, but doesn't help us in terms of progression or even defining that.
I forgot the first question.
The last one is that there is a one more biomechanics called the Brillion microscopy by Roberto Benadi in Boston. I think is promising. So if you just heard anything about it in comparison to the Carvis. Yeah, thank you.
Regarding the definition of keratoconus, I didn't find a clear-cut definition of when we just label this as keratoconus and when we just label this as normal, and the gray zone is normal. The form first keratoconus, it was referred to patients who has normal eye, normal fellow eye in a keratoconic eye, either clinically or topographically. Subclinical keratoconus is refers to the normal eye, but with the topography you can detect some changes. So I agree with you that there is a vague definition of keratoconus in that. Regarding the Bellin Ambrosio, it is one of the tools you might be using to help you just putting this patient to refractive surgery or keep observing the patient. And it doesn't stand alone by itself to make you decide whether or not this patient is keratoconic or not. Regarding the biomechanics, I agree, and as I told you that the ocular response analyzer, it is now fading by time, and the use of it becomes less and less. But still, the data that is obtained by the ocular response analyzer is still helpful. The more talk nowadays is about the Corvus and the TBI and the CBI, and they are still in the evolution of determining this factor and what is the cutoff point to diagnose what is the cutoff by doing a lot of studies with validation of their test. So in the horizon, I don't know whether or not it will be an applicable tool just to diagnose or just anticipate that this patient might develop keratoconus. Because if you thought about it, the biomechanics of the cornea is the early thing to be changed or becoming abnormal before topographic or tomographic changes. So if we have this as a tool and it indicated that there is something abnormal, you might want to just slow a little bit and give this patient some observation time that he might develop some changes in the topography before you go in and do a laser refractive surgery for him.
Thank you.
Yeah. Saad.
So thank you very much, Dr. Hatem. I will start from where Dr. Samar ended, that there's many refractive surgeons. I saw them, they depend much on the bad display, and they shouldn't, as you said. My question is, there was one report, it shows that 1/3 of patients who develop the keratoconus, they were normal in terms of tomography testing preoperatively. And this is really a strong evidence that we need such tools like the Corvus or the Aura to detect such cases. My question is regarding the Aura and the Corvus. You show nicely that it can calculate the IOP when the cornea is thin, and this is well documented even before the Aura and the Corpus. So if the thickness is do these machines consider the thickness and the IOP when they calculate when they diagnose the keratoconus?
Yes, the index they are referring to, they are extracting it after neutralizing the effect of IOP and the effect of the corneal thickness, because if the IOP is high, you would expect more rigidity or more resistance of the cornea when they are trying to test it. And there are also, if there is lower corneal thickness, you would expect also less resistance. So these indices that they are extracting, it is neutralizing the IOP and the corneal thickness.
Thank you.
Yeah. Thank you. طيب. Want a break or you want the quiz? Quiz. I see people are getting out. Okay, okay. طيب, okay, let's go to the quiz. So.
شوف بسم الله. شاشة مشاهدة جدا. ممتاز. ريدي دكتور. افتح لك اياه. سام. كويس.
طيب. Anyone out خلاص؟ طيب. We start. People still coming. طيب. كله في مواقعه. طيب. Number 1. طيب. This patient has redness and discharge for the last 1 month. He's 22 years old. So I want you to look at the picture and tell me the finding. Yeah. أكتر من كده. طيب. إنه كانوا طيب. Swab from this patient. You look at it under the microscopy, and it revealed this. So, tell me the finding here and the diagnosis. This is the nucleus. Some round. Okay, so finding, diagnosis. Okay? Number 2. This patient, 55 years old, coming with blurry vision in the morning, which disappears as the day goes. So, finding here and here, differential diagnosis. 55 years old female with decrease in vision as she wakes up in the morning, and this blurry vision improves as the day progresses. Finding here and here, differential diagnosis. Finding and differential diagnosis. You want to write anything else? Yes, she did. Easy. Number 3. Patient referred to you from the dermatologist with some skin lesion after an insect bite, coming with some blurry vision and having this corneal finding. There was no stain by fluorescein. So, just tell me the finding and the disease etiology, causative organism. Patient referred to you by dermatologist after an insect bite, blurry vision, corneal finding. What is the finding? Which doesn't stain by fluorescein. Disease etiology, causative organism. And he has a 7th nerve also. Finding disease. What is the disease? What is the causative organism? Okay. Next question. Three-year-old child referred to you from the pediatric nephrologist for eye finding. You found this. What is it? What is the disease and what is the treatment? What is the disease? What is the treatment? Last, patient 25 years old, coming to you, seeking refractive surgery. He has -2 sphere, -2 cylinder, axis 90, both eyes. You look at him in the slit lamp and you did the topography. So, what is the diagnosis? What is the finding in topography? Easy. Disease, topographic finding. Okay? Again, 22 years old, redness discharge for a month. What is the finding and the diagnosis? Number 2, 55 years old female, blurry vision at morning, which improves as the day progresses. Finding, and differential diagnosis. Referred from dermatology, insect bite, coming with blurry vision, no stain by fluorescein. What is the finding, disease, and causative organism? Child referred from pediatric nephrologist for eye exam. You find this, diagnosis and treatment. This patient seeking refractive surgery, -2 axis 90, both eyes. You find this, what is the diagnosis and what is the topographical finding. Finish. Papers. طيب do you need the answer or it's okay? Everything is clear, right? طيب who will tell me? Yeah. Papillary. How do you think? What is the difference between papillary and follicular? Yeah. Do you see vascular in the center? It's not clear, but you know, after I brought this, يعني, I don't think. طيب. It is follicular reaction, and here anything to see? Yeah. Pseudophilic ولا basophilic? Basophilic. So diagnosis? كلاميديا ما شاء الله شاطرين. طيب. 55 years old. Diagnosis? Coronary edema. طيب differential? Fuchs and pseudophilic bullous هنا ايش؟ قتاتا. طيب ممتاز. Here. erythema migrans. ايوه ما شاء الله. Interstitial keratitis. طيب what is the disease? Lyme disease. والorganism؟ هو ده اللي قلت عليه. بوريليا وبعدين شيء طويل. بورقدير فري. طيب pediatric nephrologist treatment. Yeah, if not clinically, not visually significant, you wouldn't do anything. If clinically significant, you would try cysteamine drops, or in severe cases, your transplant. طيب elucid finding. ممتاز. Against the rule of stigmatism. طيب. Any question? طيب, shall we proceed to the case presentation? يلا, let's go.
طيب, we have 10 minutes each, huh? Who will start? عمر.
Okay. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. My name is Amar Hadlag. I'm on R3 from KSU program. I'd like to thank Dr. Hatem for supervising this case. This is a patient came to the ER. He's a 53 years old, diabetic, hypertensive, and hypercholesterolemia. Came complaining of decrease of vision and mild pain in his right eye for the past 2 days. The pain is on and off for the past 2 years, but the decrease of vision only started yesterday, suddenly associated with increased hearing. There is a history of previous eyelid surgery around 3 years back, history of previous visit to the private clinic for this mild pain over the past 2 years, which was treated as dryness and treated with lubrication and punctal plugs. There is no history of autoimmune diseases, no joint pain or cough. He had vertigo all over his body. On examination of on slit lamp examination, he had a VA of counting finger in the right eye, which is the eye he's complaining of, and 20/30 on the left eye. He had lag of thymus in both eyes, moderate injection in the affected eye, quiet in the other eye. He had a peripheral 360 new vascularization in both eyes, 4/3 thinning inferonasally in both eyes, with patch of iris plugging the thinning in the right eye. With mild pressure, there is micro leak with fluorescent. An AC in the right eye is very shallow, a iridocorneal touch inferiorly, and superiorly there is a bit of formed AC with a +3 AC cells. The left eye is deep and quiet, and the lens was clear on both eyes. This is a picture of both eyes. You can see this one is the right eye, and there is a mild iridocorneal touch, and this is the left eye. So the diagnosis was spontaneous corneal perforation in the right eye, and the plan was to admit gluing of corneal perforation and cover it with BCL, fortified antibiotics, and lubrication for the left eye. Next day, the cornea stopped leaking, still the same area of thinning, but glue is in place and no more leak. The AC started to form. AC reaction is better. So kept on the same medication, and at that time anterior segment was consulted. And this is the picture post-gluing. So after the evaluation of anterior segment, the impression was corneal thinning in both eyes plus spontaneous perforation in the right eye. The differential diagnosis of such a case would be an exposure keratopathy, PUK, and neurotrophic ulcer. I mean, in regard of the whole picture and history. So their plan was to do permanent temporal tarsorrhaphy for both eyes, and to rule out autoimmune and infectious disease. That's why all of these investigations were done. So I'll speak briefly about all three differential, just briefly, so I don't take much of time of your time. So I'll start with exposure keratopathy. It's a corneal disease process resulting from incomplete eyelid closure, either due to dynamic lid closure abnormality or proptosis preventing the lid closure. Risk factors for lag of thalamus include all of these: neurogenic, like a seventh nerve palsy, for example; neurodegenerative, like Parkinson; cicatricial eyelid diseases; Botox injection, blepharoplasty or ptosis repair; and skin disorders like Steven Johnson. In clinical presentation, usually they present, it's a spectrum. So they start with punctal epithelial keratopathy, usually over the inferior third of the cornea. Then it would involve the whole cornea. They start to develop epithelial defect, then ulceration and melting, and eventually perforation. Symptoms might include range from foreign body sensation, photophobia, tearing, decrease of vision, and maybe asymptomatic, especially if there is an element of aesthesia. The goal of management in exposure keratopathy is first to identify and treat the underlying cause, abnormal eyelid configuration, proptosis, lag of thalamus, and these things, and then treat the complication. So it's a stepwise management. Start with non-preservative lubrication in daytime plus ointment at bedtime, and consider taping, especially if the issue is mainly at nighttime. Consider punctal plugs. If the case is self-limiting or temporary, you can do temporary measures like a temporary tarsorrhaphy or just a taping of the eye. If the case is related to eyelid abnormality, definitive management, definite intervention of the eyelid must be done, and correction of the eyelid position is mandatory. In most cases, a permanent solution such as permanent lateral or medial tarsorrhaphy or gold weight implant is needed in these cases to promote the eyelid closure. I'll speak also briefly of PUK, peripheral ulcerative keratitis. It's a group of inflammatory diseases characterized by peripheral corneal thinning. They present symptomatically with pain, redness, tearing, photophobia, and decrease of vision, or asymptomatically. Clinically, it is a destruction of juxtalimbal corneal stroma in a crescent shape with conjunctival injection, plus or minus clear involvement. This is a differential diagnosis of PUK in general. We can see there you can divide it into ocular and systemic. Ocular, infectious or non-infectious. Infectious, bacterial, viral, fungal, or non-infectious like Morin's, Terran, pellucid marginal degeneration, and these things. Systemic infectious also, and non-infectious. Infectious like TB, syphilis, varicella, versus non-infectious like rheumatoid, giant cell arteritis, Wagner, and celiac. Last thing I'll talk about is neurotrophic ulcer, neurotrophic keratopathy, which is a corneal degenerative disease characterized by a reduction or absence of corneal sensitivity or corneal sensation. Usually they are asymptomatic, secondary to corneal hyposthesia, but might complain of blurring of vision or decrease of vision, especially if there is scarring or perforation. Important to evaluate a neurotrophic ulcer is corneal sensitivity, corneal staining with fluorescent and rose bengal or lissamine green, Schirmer test, and corneal scraping if infiltrate is suspected. The most common cause of neurotrophic ulcer is usually herpetic, but these are all causes of neurotrophic ulcers with persistent PA defect, including damage to the trigeminal nerve, CVA, aneurysms, multiple sclerosis, tumors, leprosy, toxicity from antibiotics, and diabetes, type 1 or 2, and familial dysautonomia like Riley-Dale syndrome. There is a classification called Mackey classification of neurotrophic keratopathy. It's a 3 stages classification. Stage 1 would be hyperplasia or irregularity of the epithelium evolving to punctate keratopathy, corneal edema, neovascularization, and stomach scarring. Second would be recurrent or persistent epithelial defect, mostly in the superior half, and usually it's an oval shape, and the margin is characteristic smooth and rolled edges. Third would be stromal involvement leads to corneal ulcer, Milton, and perforation. Thank you so much.
Next, Ahmed Rubian.
Assalamu alaikum. I'm Ahmed Rubian. I would like to thank Dr. Hatem at the beginning. This is more of a literature review other than a case presentation, but we'll start with a case. Here is a 65 years female. She's a diabetic hypertensive, a one-eyed patient with a previous history of herpetic keratitis and a history of perforation تقريبا 1 year back. At that time, gluing was done and tarsorrhaphy was done. She presented تقريبا 6 months later to us with the same picture. She was having pain and redness. We saw the patient, VA was hand motion with the lid swelling, conjunctival injection, with a very severely injected eye, and as you can see here, very deep corneal infiltrate with leak. We did the scraping, and also a glue was applied. Here's another picture, here's another picture. So the culture turned to be a Klebsiella, and it was sensitive to gentamicin. So patient was started at gentamicin, doxycycline, acyclovir, and Vegamox. Later on the course, patient was started at Bridforty. تقريبا 3 to 4 weeks, patient start to get better. Pain was less, injection was less, and a leak was actually not there anymore. So a tarsorrhaphy was applied. So during this is the picture 2 weeks later. During the course, we were thinking of doing a PKP for this patient because she was not responding at all. Then the option of doing a penetrating keratoplasty was there. But thanks God, patient improved, and we did not go into that stage. So I'll speak about the therapeutic keratoplasty in a patient with a microbial keratitis. In Singapore cornea transplant study, they report that 13% of all transplant were actually required for therapeutic purposes. 17% of all grafts was done in Brazil was for perforated corneal ulcer. The indication of doing a keratoplasty in patient with microbial keratitis included that if the patient is not responsive to medical management, and if the globe integrity was compromised, and if there is any scleral involvement. Here is one review I found very nicely illustration of the indications of keratoplasty in microbial keratitis. They included if there is any refractory, to the maximum medical management, or there is an extensive corneal involvement, a desmatocele, or there is a perforation, and scleral involvement. Usually the underlying cause of microbial keratitis makes a difference. A patient with bacterial keratitis are less likely to require a transplant in comparison to a fungal keratitis, for example. In a series of 66 patients with fungal keratitis, they required transplant in 38% of their cases, which is almost 1/3 of the cases of fungal keratitis. Here is a comparison between the different study published regarding this issue. The cure rate actually was very high in bacterial keratitis compared to fungal keratitis, and the success rate was actually a little bit lower in the fungal keratitis group. Here is a recent paper I found was published in Cornea last February about the outcome of therapeutic keratoplasty in hopeless microbial keratitis cases, and otherwise patients was going for evacuation. So here is a 28 patients with severe microbial keratitis included in 2 or more quadrants involvement of the limbus or 180 millimeters of the cornea. All of those patients were actually advised for evacuation by 1 or more ophthalmologists. And surprisingly, the success rate was in the 22 patients out of the 28, a complete success in 10 and a partial success in 12. A failure was around in 6 patients, and 2 patients actually ended by an evacuation. And again, they mentioned that also the fungal keratitis group were actually poor outcome compared to the bacterial keratitis. Here is one of their patients. If you can compare the pre-op picture, it's almost limbus to limbus corneal infiltrate, and 45 days after, it's kind of a clear graft. Here is another patient with a similar picture. If you can see after 100 days, it's a very nicely clear graft. But it's not always the story. Here is one of their patients actually developed an endophthalmitis in day 6 and ended up with this picture down there. So what about doing an LKP for microbial keratitis? This is another question of this story. Here is a paper published in Ophthalmology 2009 comparing doing penetrating keratoplasty to a limbal keratoplasty. So in this paper, they included 126 patients. 26 of them, they actually underwent an LKP compared to 100 patients with a PKP. The therapeutic success was 84% in the LKP group compared to 88% in the PKP group. The best corrected visual acuity, at least of 6/9, was achieved in 50% of the patient with LKP compared to 20% in a patient with PKP. And the survival rate was actually a huge difference between the LKP and the PKP after 1 year. So this is one of the patients with the Streptococcus pneumoniae, and patients underwent an LKP and turned to be a very nicely clear graft after 1 year of this intervention. Another patient, this is a recent paper, was talking about the fungal keratitis, doing an LKP and a fungal keratitis. They included 23 patients with an active fungal keratitis affecting the optical zone of the central 6 millimeter. The infiltrate was deeper than 150 micron, but not exceeding 300 micron. This is their inclusion criteria. They did the big bubble technique in around 75% of the cases, and all of the patients actually tend to have a clear cornea post-op, and no recurrence or infection, and no rejections or graft failure after 32 months of follow-up. Finally, this is another group. They did an LKP for patients with acanthamoeba, 12 patients with an active acanthamoeba keratitis. They did an early intervention between 30 to 60 days from the onset of the symptoms, and all of the patients actually had no recurrence or rejection. So it's quite interesting. So the presence of infection and severe inflammation at the time of the surgery makes the post-operative care very challenging. Surgery provides a structural stability, and ambulatory vision can be preserved. So evacuation is best avoided in cases of infection that is limited to the anterior segment. Even in hopeless eyes, every eye deserves a fair chance. Thank you.
Thank you, Ahmed. We can have 1 or 2 questions on the first 2 cases before I forget them if anyone has any question.
Thank you, Ahmed. Can we
points the indication of keratoplasty in cases of مثلا microbial keratitis, fungal, bacterial, viral. We know the indication of giving oral, for example, and we know in fungal we usually have low threshold. But can we say مثلا if it's more than 2 quadrant, if it's around more than 180 degree, if it's reached the limbus, there's an indication to go for keratoplasty immediately. Do we have indications like this, fixed indication?
Sure. And the paper I showed اللي هو literature review اللي كان مسوى على a lot of studies, the 3 indications, the one I showed, if there is no يعني response to the medical management, this is one, and it is a progressive, and if there is a perforation, and if there is a corneal involvement, I mean a scleral involvement, sorry. Those are the 3 indications, but numbers يعني تقول والله how much is the scleral involvement, and then I'll go to a PKP, or should I wait and treat it as an infectious scleritis, then I'll see. I could not find. I was looking for this answer because that was the answer for our patient, whether to go or not to go. But والله I could not find something specific talking about when to go, يعني a clear cut when to go to transplant. ما في شيء واضح لقيته. الدكتور حاتم.
Usually you resist doing any corneal graft in an infected eye. Unless it is going to the sclera and you are suspecting fungal, for example. Even if it perforates, usually I put glue and continue with medical management, unless perforation is so big so that no glue can handle that and the eye might go into choroidals or phthisis. That's the time I go in and I do grafting. Regarding LKB versus PKB, yes, the decimate is a good barrier for organism not to go inside the eye. But mentioning that what is my indication for surgery, I usually do grafting whenever it reaches deep and perforated, so there will be no place for LKB. And I don't think it's justifiable if the inflammation or the infection is the anterior corneal surface to go for LKB. You still have a chance to salvage this by medical management. Okay. Next is Ziad Al-Harbi, infectious scleritis.
يعطيكم العافية. I'll try to do this as fast as I can. So our case is a 66-year-old man who was referred to the anterior segment division of King Abdulaziz University Hospital after being admitted with the suspected diagnosis of endophthalmitis. He's diabetic on incidence, status post-cataract, and viscocanalostomy 3 years ago. He presented with a history of 1 week of pain, headache, and a red eye, with a patchy necrotizing conjunctivitis with scleritis and retrocorneal abscess. Examination proved that the patient does not have endophthalmitis at that time. This is the picture at presentation, as you can see. So since he was admitted, rescraping was done, IV antibiotics were instilled, plus fortified topical antibiotics, Vanco and Cifta as per our regimen. Day 2, the keratitis increased, the melting increased, the patient was rescraped with the new media and started on, because of high suspicion of fungal involvement, with oral voriconazole and topical natamycin and voriconazole. This is the picture the second day. So at day 3 and 4 of admission, some of the results came back with heavy growth of strep pneumonia. The red reflex became dimmer. B-scan was suspicious for endophthalmitis. So retina were consulted and they advised for tap and inject, and anterior segment division also elected to do intrastromal and subconjunctival antibiotics. And the patient was pushed to the operating room for scraping and biopsy. During the course of his admission, the scleritis with the same medication stabilized, the hypopyon increased, vitreous inflammation increased, and again, retina chose to re-inject the eye. Multiple intrastromal and subconjunctival antibiotics were injected as well. There was no signs of extraocular involvement. There was also hyphema. At day 8, the patient was stable. He had less melting, decreased hypopyon, and the fungal results came back negative, and the patient was stopped of antifungal medication. This was his picture. During the course as well, he developed a choroidal detachment. The eye got soft. The melting halted, there was no perforation at that time, and the medications were tapered. On day 12, he was discharged on topical Vigamox, Predfort, Provera, and doxycycline. To be honest, this patient was supposed to be coming today to the hospital, and we were going to take new pictures, but since we came here earlier, I wasn't able to do that. This patient was discharged last week. So in regards to infectious scleritis, which is our topic today, general scleritis is an indolent, painful, locally destructive inflammatory disease. The majority are inflammatory. Some studies have said that 5 to 10% are infectious in etiology. The predisposing factors for infectious scleritis are either to inoculation occurring during a trauma or surgery, or spread from local tissue, especially keratitis, indigenous, and also from endophthalmitis. The overall visual outcome in infectious scleritis is worse than autoimmune, and that's usually due to the delay in the diagnosis and because of aggressive nature of the organisms involved. So the delay in diagnosis is due to the high similarity that it has with autoimmune etiologies, and because of the prior use of corticosteroids in the majority of patients before infectious process is suspected. And as you know, the corticosteroid will decrease the immune response and also maybe increase tissue destructive properties of the organism. Also, there is a prolonged interval between injury and presentation. And because of the sclera is an avascular tissue, it might take a long time for the infection to develop and to progress. Also, the presence of predisposing factors such as trauma, surgery, and diabetes. Microbiological organisms involved are viruses, fungi, parasites, and most commonly are bacterial in origin. Pseudomonas represents in one study 85% of the cases of bacterial scleritis. Staphylococcus was there also, usually in local disseminating disease such as that's post-regime surgery, Streptococcus pneumonia as well, and Haemophilus influenza mycobacteria, especially in the very young and very old. Fungal scleritis has an overall worse outcome. Pseudomonas is very aggressive. Since it's presenting 85% of the cases, more studies have been done on this, and it was due to the collagenases, proteoglycanic enzymes, and the proteases, which lead to a rapid tissue breakdown. So the signs and symptoms of the disease, history, usually the patient comes with a severe pain and redness, which is usually identical to inflammatory scleritis. They have sometimes ocular surgery history, such as pterygium, cataracts, vitreoretinal surgeries with use of mitomycin or cryotherapy. Trauma, either penetrating chemical, or usually some cases I've read that only mud was spilled in the eye and then later that patient developed infectious scleritis. Contact lens wearers, immunosuppression. One study found that 89% of patients with infectious scleritis had diabetes mellitus. Patients usually come with an indolent course, especially in fungal and mycobacteria, and the history of either concomitant or previous herpetic keratitis, and that might guide you into the diagnosis. The signs, 93% of the cases during the course of the disease, they will have scleral necrosis, but that's not the inciting event or the presenting symptom or sign. Early in the course, only chemosis and hyperemia, which is definitely similar to an inflammatory process. This might progress to nodular and necrotic scleral lesions. Sometimes, especially with herpetics, they have diffuse anterior scleritis with no specific nodular inflammation. They might have yellowish scleral abscess, which is under an intact conjunctiva. They can be single, multiple, or they can coalesce into larger abscess, and which progress to ulcerate and have a uveal show. Local destruction of the adjacent tissues such as keratitis, uveitis, endophthalmitis, and myositis have all been reported. These are pictures. I'm going to go really quickly here. As you can see, the nodular appearance of these infectious processes here as well. This case is after management here. So culturing these is very important because usually you will not know that this patient has infectious scleritis unless you have a positive culture. Multiple scrapings are collected from the lesion with a surgical blade for best diagnostic viability. PCR is reserved for cases with suspected herpes or after multiple negative cultures. One study advised that, as you know, in keratitis, we have regular staining and cultures, and then we have special staining and cultures after we don't have a positive outcome. One study advised that all of these stains and cultures are done at the first time with infectious, when you are suspecting infectious scleritis, because of the indolent organisms and because of the high magnitude of tissue destruction. Ultrasound by microscopy and anterior segment OCT are usually useful in determining the depth of the scleral involvement and for surgical planning, such as if you want to do a scleral patch graft, but they are unuseful in differentiating between infection and inflammatory process. All patients deserve a standard uveitic workup. The majority, we have to not forget, more than 90% are inflammatory in origin, and sometimes they might be life-threatening inflammatory scleritis. And the step-ladder approach to scleritis must be adhered to in all cases. When you are suspecting an infectious process, you are guided to that with more scraping, more culture, higher attention to the patient, but that does not and should not sway away from treating the patient in a stepwise manner. The treatment is usually delayed because of this issue, and it is difficult because the sclera is avascular. It's largely dependent on the specific organism and the sensitivity to your antimicrobials, and it's a combination of medical and surgical. One study found out that only 18% resolved with medical treatment alone. Pseudomonas and fungal are very aggressive, and they always require surgery based on multiple reviews. Medical therapeutic options are topical and systemic antibiotics, subconjunctival injections. Topical and systemic steroids are controversial but might be useful later in the course of disease after controlling the infection. Glue is an option if you are in a situation when you have a perforation or impending perforation. Surgical intervention is recommended in all cases because they need surgical debridement. Adequate material for microbiology and histopathological evaluation is very necessary for a prompt identification of the etiological organism, which will lead you to targeting that organism with a tissue or with an organism-specific antimicrobial. The idea is to debulk or deroof the abscess and to debride any necrotic infected material, and to remove any offending agent such as a foreign body. During the debridement, all necrotic material should be debrided until you see healthy tissue. You might use cryotherapy. Some of the authors advise not to retract the conjunctiva for better penetration of your topical antibiotics. A scleral corneal patch graft might be considered. Repeat debridement is, you should not be shy of doing repeat debridement for such patients. And subpalpebral lavage of antibiotics can be inserted for better availability of the antimicrobes. As you can see here, it's been used in some studies and proven effective. So that patient stays like this for, with continuous irrigation with antibiotics. The prognosis of infectious scleritis is usually poor, and it's highly dependent on the presentation when the patient presented and the course of the management and what complications developed. So in conclusion, infectious scleritis can be challenging for both in terms of diagnosis and management. It mimics immune-mediated scleritis. Diagnosis is largely dependent on identifying the organism. Medical management is usually not enough. Identification of the infection early in the disease course and prompt institution of appropriate medical therapy with surgical debridement can help achieve a better outcome. Delayed presentation and poor visual acuity at presentations are the most important factors associated with poor outcome. Thank you very much.
Thank you, Ziad, for the nice case and review. Any questions for Ziad before we move to the last case?
Okay. What is the, yeah?
Because the sclera is avascular and tissue penetration of systemic antibiotics is not usually that good, and the organisms are highly destructive. And the idea is to have constant irrigation with antibiotics at all times to decrease the load on the ocular surface.
But it is on the lid, right?
It's through the
To the sclera.
subpalpebral.
Oh.
Maybe the picture was not so clear. It is through the lid. So this cannula is inserted in this opening here, and the antibiotic is instilled through the lid to have constant irrigation.
السلام عليكم. بارك عليكم الشهر جميعا. So I'm going to talk about a case of Marfan syndrome. I'm Tariq Zahim, third-year resident in KSU training program. Thanks for Dr. Karantan for the provision and supervision of this case. My patient is a 22 years old female with a known history of Marfan syndrome that came complaining to the clinic or in the clinic with poor vision in both eyes for a long time. She has been seen by ophthalmologists before, and they told her that she was having a problem with her lens and her retina, and her past surgical history revealed BLAR4XT. Her family history is negative for Marfan syndrome. On examination, her best corrected visual acuity using contact lenses was 2200 in the right eye and 2050 in the left eye, using minus 18.5 diopters in both eyes. External examination was normal, as her pupillary examination, extraocular motility, IOP. She was having a 20 prism diopter ET, which is possibly a consecutive ET from her last BLAR, and she is fixating with her better eye. Anterior segment exam showed a temporally subluxated lenses in both eyes, and this subluxation does not bisect the pupil. And the angle was deep in both eyes. And her dilated fundus exam showed high myopia with chororetinal atrophy at the macula. And this is an anterior segment photo of the right eye showing a temporally subluxed lens, and you can see nicely the zonules attached to the capsule, and this is a retroillumination of the same photo showing the same findings. So the impression of this patient is this patient is having Marfan syndrome with poor vision associated with subluxated lens in both eyes and high myopia and macular chororetinal atrophy. And the plan is to observe the patient with no surgical intervention, refraction, referral to medicine and cardiology, and follow-up in addition to ERPRN once the patient is having any ocular symptoms. So what is Marfan syndrome? Marfan syndrome is a pleiotropic autosomal dominant disease. Pleiotropic means a single gene is having multiple effects, and at least 25% of cases result from a new mutation. This mutation results in weakening of connective tissues in the musculoskeletal, cardiovascular, and ocular organ systems, and the abnormality in over 80% of Marfan patients involve defects in the protein fibrillin-1, as you know, which is abbreviated as FBN1 on chromosome 15. And this protein is a structural component of microfibrils found in connective tissues throughout the body. More than 500 different mutations in FBN1 gene have been identified, and another mutation, which is believed to result in Marfan phenotype, is the inactivation of transforming growth factor beta receptor 2, which is thought to disrupt the integration of fibrillin into connective tissues. The diagnosis of Marfan syndrome is complicated by genotype-phenotype inconsistency that presents with widely variable clinical manifestations. The clinical diagnosis is currently based on Ghent nosology, which was first proposed in 1996, and it involves the description or involvement of at least 3 organ systems, including skeletal, ocular, cardiovascular, matter, pulmonary, or skin. And this diagnostic criteria was revised in 2010. Marfan syndrome can also be diagnosed with equivocal genetic testing, which can be offered to patients in the context of family planning and pedigree formation. So the systemic manifestations of Marfan syndrome are well studied, and the most obvious of which are the musculoskeletal abnormalities. So the Marfan patient, as you know, is often very tall with long flexible extremities and marked scoliosis, and they exhibit arachnodactyly, which is known as spider fingers, with the ability to dramatically encircle the wrist, which is known as Walker-Murdoch sign, as you can see at the bottom of the slide. In addition, they often have pectus excavatum or carinatum, high arched palate, and facial abnormalities. The cardiovascular findings range from mild mitral valve prolapse to severe aortic aneurysm or dissection, and the severe cardiovascular complications are the primary cause of mortality among Marfan patients. The most common findings in the lungs are subpleural apical blips, which can rupture, resulting in spontaneous pneumothorax. Others include emphysema and abnormal lung functions, and 19% of those patients showed restrictive pattern, 44% an obstructive pattern, or an isolated diffusion impairment. A case series in 1998 described multiple gastrointestinal complications in persons with Marfan syndrome, namely diaphragmatic hernia, inguinal hernia, diverticulosis coli, and Zenker's diverticulum. So going to the ocular manifestations of Marfan syndrome. The major ocular abnormality in Marfan syndrome is ectopia lentis, and the exact mechanism of this ocular pathology is not known, and a number of theories have been proposed. And one study found that while fibrillin is localized to the superficial capsule and ciliary epithelial surface at the attachment of the zonules in normal eyes, Marfan patients lack such localization and exhibit abnormal ciliary processes with absent or severely disorganized zonules. Clinically, as you know, the patients present with ectopia lentis, and it is bilateral in 60 to 87% of patients and is stable from childhood. Symptoms include fluctuating blurred vision and monocular diplopia. And on examination, patients demonstrate refractive instability with myopia, astigmatism, iridodonesis, phacodonesis, and the most common direction of dislocation on exam is superior-temporal. Retinal tears and detachment are also quite common in patients with Marfan syndrome, and the Marfan eye has many risk factors for tears and detachment, including high myopia, excess lattice degeneration, vitreous liquefaction, choroidal and scleral thinning, and vitreous traction from ectopia lentis. Each of these changes is thought to be related to the fibrillin alterations that we have talked about earlier. Retinal detachment occur in 5 to 26.5% of patients with Marfan syndrome and is bilateral in up to 42% of the cases. Rigorous screening and close follow-up of symptoms is important to prevent retinal detachment in these cases. Other ocular manifestations of Marfan syndrome include cornea plana, megalocornea, keratoconus, blue sclera, iris coloboma, cataracts, glaucoma, strabismus, and amblyopia. With regard to ectopia lentis, a number of treatment options exist. Patients with mild subluxation allows for near normal vision, with the patient seeing through the phakic portion of the pupil. And the other extreme would be severe subluxation in a child, which requires urgent surgical correction to avoid irreversible amblyopia. Surgery is indicated when the lens edge is bisecting the pupil, in which the optical correction is impossible, and when the lens is posteriorly dislocated into the vitreous, and when the lens is dislocated anteriorly and causes secondary glaucoma, or in the setting of cataract formation. The principal surgical method employed in Marfan syndrome is lens extraction with either IOL placement or contact lens correction. Because of the altered anatomy and weakening of the connective tissues in Marfan syndrome, all of the usual complications of lens extractions are amplified. As the capsule is unstable from loss of zonules, the IOL must either be placed in the anterior chamber or be secured to the iris or sclera with permanent Prolene sutures. Another surgical option is to secure the capsule to the sclera using suture Sioni modified capsular tension rings or Ahmed capsular tension segments. One important complications of IOL fixation to the sclera in young patients is that the 10-O Prolene sutures may break 3 to 10 years following surgery. And this has led many surgeons to use a larger suture, such as 8O Gore-Tex or 9O Prolene in the hopes that the suture will last longer. In cases of complete posterior dislocation, a parsband vitreolenzactomy can be performed. And these are my references, and thank you very much.
Tariq, any question for last case? Any comment?
I have a question for the. Thank you, Tariq, so much for this amazing presentation. For the Pentacam presentation, now we hear about the role of PRK in keratoconus patient or form thrust keratoconus. Where are we from there, and should we do it or we shouldn't follow this protocol and all these things?
There are many studies and many people are practicing this in early to moderate keratoconus, and they do some PRK just to trying to regularize the cornea to get rid of all the refractive error, in addition to the cross-linking itself. And this some people are with this concept and some people are against, and both of them are justified. And if you are doing only just a touch to just normalize the cornea and do the cross-linking, you should take into account that the cross-linking itself has some flattening effect after a year time. So if you are treating fully, some patient might end up in the hyperopic state. So I think based on the data available, it is justifiable in certain cases to go for just this PRK with cross-linking. I don't do it.